Thank you so much. Hi, everyone. Today, I'm just going to check if my slides are working properly. Yeah, they are. Okay, I'm going to be talking just about some issues in pain management. I work as we told, medical lead in the Ehlers-Danlos Syndrome Program. We see a lot of patients on a daily basis. Usually, the patients are referred to us with complaints of hypermobility because that is what initially starts affecting people, usually if they're not recognized in their infancy or in early age. But then we also end up making some diagnosis for patients with Marfan's. Loeys-Dietz, by the time it presents early, if not late, so we don't see too many of them. So I don't have any disclosures for today's presentation, but I'm a big fan of Twitter, and if you guys like Twitter as well, please feel free. Let me see if the points, yep. Okay. Yeah, and today, in the next 15, 20 minutes, I won't bore you too much with long presentation. I have kept it really short and very succinct. So we'll just talk about a bit about the spectrum of joint hypermobility. When I say the spectrum, we know that a lot of patients in general population have hypermobility. Around, if we go by the estimates, it varies between 6 to 57% of the population. But on an average, experts agree that around 13%, 12 to 13% of the population has hypermobility. But that hypermobility can extend from a single joint to the involvement of multiple joints. So what we'll do today is just understand what the difference of single versus multiple joint hypermobility means in terms of diagnosis and early detection of disease and appropriate management. We'll just also touch on some evolution of chronic pain in patients with pathological hypermobilities. And finally, I'll just enumerate some common pain management approaches. My goal today is to give you some take-home messages which you can utilize in your day-to-day life to manage your pains effectively. As we know, connective tissue is an integral part of our body, and they provide support to the body. And just as the woman here was asking the question about what comes first, is it the heart that disease comes first, or the skeletal system? It's just the connective tissue, which is like a major part of our body and affects several different systems. So there's no really chicken or egg condition. It's a multifaceted disease. All of these connective tissue disorders are. For relevancy to this presentation and the audience today is that we'll talk about collagen. Collagen is essentially the tissue which provides, it's a binding glue which provides strength to the tissues. And whereas elastin, which includes the elasticity in general, is provided by elastin and fibrillin. Important difference here, which I'll also touch later, is that collagen provides strength, but in general, collagen is very fragile tissue. It is not at all elastic, whereas elastin is what provides elasticity to the tissue. What it means is I'll talk a bit later as well. Joint hypermobility in general is a very common but often neglected and under-recognized physical sign. What it means is that patients' joints move beyond the normal ranges. It is by itself, by no means it's a medical disease. Often it's familial, but it's also seen commonly in children. Children are more hypermobile than adults. Women at any age are more hypermobile than men. Then also certain surgeries can induce hypermobility. Inflammatory arthritis like rheumatoid and deformities can cause hypermobility as well. And also sometimes we know that hypermobility can be amplified by the use of exercises and tone. So how do we differentiate between inherited and acquired hypermobilities? Usually the thumb rule is that if the patient has single or two-joint hypermobility versus a multi-joint hypermobility, it is kind of a way you can figure out if it is pathological or not, or if it may be because of an inherited disorder of connective tissue metabolism. In general, it's associated with collagen or elastin. And as we age, be it with both sexes and as we grow up, the hypermobility decreases as more and more arthritis takes over. So what is the difference? Why should we worry, and when should we worry about pathological joint hypermobility is very important to understand, because the more we understand what it is, the more we are more informed and we can take care about it and we can address these issues. So usually if it is causing a lot of pain-related issues, a lot of muscle pains, joint pains, recurrent joint injuries, subluxations, dislocations, if the patient then feels that they have stretchy skin, if they start having some cardiac events, if they have any poor healing qualities, that is when we have to start to worry that it might be a pathological variant associated with it. The common disorders of hypermobility we all talk about is Ehlers-Danlos. I just put it up because I work in EDS service, but otherwise, yeah, Ehlers-Danlos, Marfan's, and Loeys-Dietz. Important difference, again, I'll point out here, and what I want to emphasize also is that cardiac issues in all these three syndromes are a bit different. Collagen, in general, provides strength, but it's very fragile. So usually, most of the patients in vascular EDS or other variants of EDS are recognized after the initial cardiac event, in spite of their previous echoes and other imaging being normal, because it's fragile. As soon as there's a high risk of or risk of pressure or tear, which happens, the collagen just gives out, and the patients have arterial dissections or other stuff. Whereas in Marfan's, it's because of the elastin, and because of elastin, which has elasticity associated with it, it kind of gradually balloons out instead of having a sudden tear. And the Loeys-Dietz also is related to TGFR and other genetic mutations, which affects the extracellular matrix and then causes its manifestations classically. What I want to talk to you about is the evolution of chronic pain in all these pathological hypermobility disorders. And it's interesting that the natural history of chronic pain development in all these hypermobility spectrum disorders is also very flexible and ever-changing. It usually starts in a young age when the patients, because of their hypermobility, they have certain dislocations or subluxations. They injure their soft tissue, as Dr. Ole was saying. They may injure the ligaments, cruciates, or medial collaterals. And because of this soft tissue injury and inflammation, they develop what is called as like a nociceptive pain here. Yep. They develop nociceptive pains. As they continue to grow, because of the fragility of this connective tissue, they suffer a lot of repetitive strain injuries earlier than what other patients or other people would do. So they start getting a lot of widespread musculoskeletal pains due to these repetitive strain injuries. And then also our tendons, bones, and ligaments also start get affected. And then they develop enthesiopathies and also certain non-articular manifestations, usually in Ehlers-Danlos is gastrointestinal, pelvic issues, and headache. After this, what happens due to this continuous barrage of stimulus, afferent stimulus, which comes from the pain fibers, the nerves start getting irritated in a long period of time, and the patients start developing nerve pains, which are essentially burning, tingling, numbness, paresthesias, altered sensations. Due to the laxity of the ligaments, these symptoms can often be transient initially, but later on they move on to be very chronic as well. One other common feature which is under-recognized in terms of nerve pains in patients with connective tissue disorders is that all the nerve fibers of the peripheral nerves have an extracellular matrix which is composed of collagen and elastin. And the patients who have connective tissue disorders don't really form these networks very well. Because of this, their A delta and C pain fibers don't respond to pain very well, and they have abnormal pain sensations. Eventually, due to all these chronic pains in the peripheral nervous system, the changes start to happen at the central level, where cellular changes in the nerves and also the brain, which is constantly responding to pain, starts being centrally sensitized, and then the patients start developing constant increased feeling of hyperalgesia. The pain sensations, the normal sensation which is not perceived as painful by other people, are started being felt as high pain in these patients, and eventually they turn out to having multisystemic issues of severe fatigue associated with pain and the visceral complications. So the approaches in pain management, usually we all know now, there's a huge emphasis on multidisciplinary treatments. The way I remember it is with my 5 Ps is there's the patient education, physical therapy, psychotherapy, procedures, and pharmacological therapy. One thing I would like to emphasize here for everyone is that the goals of long-term care are always self-management. Self-management, self-management, and self-management. This is what would help the patients to have better quality of life in long term without the need of seeing the physicians on a regular recurring basis. First of all, so joint stability is one of the most important factors that needs to be considered to prevent any injuries. If the patients who are hypermobile, they are more prone to develop these injuries. They have more repetitive strain, trauma, more incidence of subluxations and dislocations. So joint protection strategies are different ways to do things in a manner that you are not prone to more injuring of your joint. It's very important for patients who are hypermobile to be conscious of this and accordingly modify their activities. Usually what you can do, you can use some external brace. A proper posture is how you start things with. And then also in our clinic, we often tell patients not to do repetitive activities for long duration of time, take breaks after 30 minutes from what they're doing. Bracing is helpful sometimes. You can use the bracing in the form of taping. It could be in the form of hand braces, finger braces, or elastic wraps. But two important things which are considered with bracing is that bracing should only be used for two kind of occasions. The first is if you have an acute dislocation or subluxation, so to tide over that event, reduce the inflammation, and to facilitate the recovery, the bracing should be used for short periods of time. The other thing is if you're very prone to subluxation or dislocation, you can start with using the bracing, but the long-term goal should be to develop adequate tone of the muscle so that you can take the brace out. Because if you use the braces for a long period, what they do is that they weaken your muscles, so you're actually doing more harm to yourself in the long term. Ergonomic modifications, like using, depending on what joints are hypermobile, you can have workplace modifications. Desktops can be set up in a different way, and you can use help of an occupational therapist or a workplace ergonomic consultant to kind of have some changes in your day-to-day schedule to avoid repetitive strain injuries. Important issue is joint stabilization surgery. A lot of patients come to us and ask about the joint stabilization surgeries. Dr. Ole touched a bit about it. There's a huge literature and which says that it's like a 50-50 thing, very, very conflicting data, which shows that there may or may not be benefits with stabilization surgery in these patients with connective tissue disorders. The reason being is that the tissues are very fragile, and the surgeries, the long-term outcome of the surgeries are not as good because the tissues tend to kind of break out again and again. However, if it is if we use with some specific set of precautions, the surgeries are still helpful in a very few appropriately chosen subset of patients. Physical therapy is another very important strategy to help manage your day-to-day pains and also prevent any subluxations or dislocations. Just to understand the exercise recommendations, I want to show you the difference between muscle tone versus muscle strength. So strength is, when we develop muscle strength with high big biceps, is that usually it's the muscle's ability to contract and create force in response to the resistance. However, tone is kind of a resting state tension of the muscle. So in patients, every patient who has pathological joint hypermobility, they should focus more on developing the muscle tone. Because if the resting state and tone of the muscles is better, they would have less chances of getting subluxations or dislocations, which may make them also more prone to arthritis and all. Also, what happens is that the tone-developing exercises send signals back to the body from the Golgi tendon organs, so they're able to perceive better, they have better proprioception, and they're able to better perceive the position of their body in the three-dimensional space. That is also another helpful thing with tone-developing exercises. The usually exercises which should be done are lower, non-resistance based. You should do, so only use minimal weights, but add more repetitions, do it gradually, and should be done for several repetitions. Should start low and go slow is the usual thing. Also, you should gradually pace yourself, work at your own pace. In the long horizon, it takes months to stop getting worse, and within a year or more, the patients actually start getting better. There's no quick fix to get your mobility better. Avoid hyperextension. Some things which should be avoided, high-impact exercises, resistance-based exercises are not really good in these patients. And also be caution. You should need to exercise caution with using elastic bands and weights. Lastly, the few pharmacological approaches. I think this is where everyone would know a lot about using Tylenols, your NSAIDs when you have pains. With muscle relaxant, and I forgot to touch muscle pain in the chronic pain model. But also, what is quite interesting, and Dr. Rowley also talked about it, is that it's hard for a normal physician who's assessing these patients to understand that why some joints are hypermobile, whereas others are stiff. So then that doesn't make sense in their scheme of things. Essentially going to the picture of zebra is that the reason why it happens is because when the patients have a tendency to sublux or dislocate more, they try to keep the muscles in a constant state of tension to avoid those dislocations. What eventually ends up happening is the muscles go into a state of constant spasms, which is called myofascial or muscle pains, and then there will be certain knots in the body, which would be the trigger points. And so accordingly, the muscle relaxants should be used very judiciously in this population, only for a very small period of time in small doses. Otherwise, if the muscles relax too much or become relaxed too much, the patients get more prone to joint hypermobility. But also important thing is, they are not absolutely contraindicated. Muscle relaxants can be used for short-term for muscle pain management in patients who have hypermobility. For nerve pain medications, the usual medications are Cymbalta, amitriptyline, and then there's Lyrica, gabapentin. Opioids are the last resort. They can be used. It's not that they should never be used, but they should be used for a goal-focused behavior. If the patients want to engage in activity, use it as a facilitator to engage in physical therapy and better quality of life, and take scheduled preventive medication, which is more effective than much just as needed. Lastly, we all know, it's very well recognized that psychological factors play an important role in the entire pain experience. Unfortunately, a lot of physicians and healthcare professionals who work in pain management still continue to emphasize and prioritize only biomedical features. The problem is kind of twofold. These patients have complex histories, and when they present to the physicians get overwhelmed, and majority of the patients have long-standing interaction with the medical community, and not often it goes very well. Patients feel invalidated and feels injustice. So it should be based when the patients are examined and when the patients are seen in the clinic. I believe in a humanitarian approach when the clinician must have empathy and validate the symptoms, the chronic pain experience of the patients, but also patients should trust their physicians on the role of psychological factors. Sometimes the patients not very often, but sometimes the patients would just dismiss the role of psychological factors that play with the mind and enhance or exacerbate the pain experience. Usual psychological approaches. There's not much literature out there specifically for psychological approaches in chronic pain. Yesterday I was looking, there was only 2 articles which have been published for evidence, which show evidence of CBT that works very well in patients who have chronic pain in Ehlers-Danlos syndrome. But we should definitely treat the comorbid depression, anxiety. We should have stress reduction, acceptance and coping, and different strategies, so on. There's also anecdotal evidence of using hypnosis and meditation, but there's no good quality literature on that. Yeah, that was just, and I think that is all for my presentation. Thank you so much.
Questions?
Thank you very much. So we're talking about, you mentioned NSAIDs, using NSAIDs. One of the things, I don't know if anybody from a cardiological standpoint wants to address it, but for our patient population, we've been told often that we should stay off anything that's an NSAID category drug.
So that is a good question. However, so what we usually do is we tell the patients to not use the NSAIDs for long term. However, if it is a very infrequent PRN usage with due precautions and using the better NSAIDs like celecoxib taken after meals. 100 milligrams is a dose which can still be prescribed.
Yeah, so we're just very cautious about that class of drug because of what it does, number one. Number two, you were talking about cognitive behavior therapy, meditation and hypnosis. We've found with a bunch of our patients that meditation works it's not an end to itself, but it's one tool amongst numerous tools. There's lots of free apps or inexpensive apps on the web that you can help you to meditate and get into it if you've never done it. That's very good. And you talk about opiates, but you didn't talk about cannabis at all. I'm wondering if you would address cannabis now that it is legally, it's legal medically for anybody that doesn't know, and it's legal recreationally. We have a series of patients that we've switched from opiates to cannabis because of we think are the benefits, and we've seen good response. So if you want to talk to that.
Yeah, so there are a few points here. NSAIDs we talked about. What was the second thing before the opiates?
Well, meditation, forget that meditation was more of a commercial to say there's meditation, try it and there's stuff to help you do it.
No, but it's good that if you have, we don't have, as I was saying, I looked at the data for all the psychological therapies. I didn't find any other than the CBT, but if it is that meditation works well, we should create a data registry for that and kind of work on that perspective. Also, what I have found personally is that a lot of meditation is, the meaning of meditation is different for different patients. It's not essentially, for some patients, they tell me that music is meditation for them. For others, some form of meditation or some kind of relaxation or breathing exercises is meditation. So it's kind of a vague term, and patients kind of respond to it in different ways. Coming back to cannabis, I agree that cannabis has a great utility. However, and I actually forgot to include it in my presentation. What?
I wasn't sure you did that. That's why I'm asking.
No, I totally forgot to include cannabis. That was a mistake. But there's evidence that, especially in neuropathic pains, if there are nerve pains, cannabis does well, especially the CBD oils. THC can be used for patients to help with sleep. It's a psychoactive compound, everyone knows, but still it can be used to the benefit. If the patients have problems falling asleep, then a night dose of THC oil can be also used. I agree.
Could you comment on the use of massage therapy or chiropractic for pain management in people with connective tissue disorders? Any precautions or concerns?
Okay, that's a good question. So for chiropractic, usually the thing is that any chiropractic therapy, again, in the traditional form, chiropractic therapy meant manipulation. But however, it is now the chiropractic therapy and the scope of the practice is also changing for chiropractors. I work in a clinic, in another chronic pain clinic with a few chiropractors, and now their approach is also more about doing a right, proper ergonomics posture and giving some active release therapies, massage therapies for patients with chronic pain in connective tissue disorders. But manipulation is one thing which should be avoided in all the patients. Again, the massage therapy should only be used if they have chronic myofascial pains to release the taut bends in the muscles. That is what it should be limited to. The pressure or the force of therapy should be low in these patients, especially in our EDS population, because they're very prone to bleeding and skin-related manifestations as well, is what we recommend.
Just from a orthopedic, so I also do adults, and we have a big multidisciplinary clinic for back pain. And that as a basis, and we have it's an osteopath or a chiro, you can turn them as you wish. If you look at the literature, the issue of osteopathy or manipulative therapy has shown that it is sometimes of use to alleviate crises, pains. And this is in patients that do not have connective tissue disorder. So they have fairly good studies that for punctual issues, they're able to alleviate some of the pain. But in the long term, a lot of people say, I go, and a day or later, the pain has all come back. And that, so there seems to be some alleviating factors. Some of the joints that are ankylosed, they seem to manage to sort of free up. And then just because of the habits and the patient's sort of underlying conditions, everything sort of, comes back tight again and you get the pain. So if you look at, from a musculoskeletal point of view, trying to get alleviation of pain, there's a lot of papers that, physiotherapy, but not even physiotherapy, just physical activity. So if you look at the ability to So they have some, nice randomized control studies. Patients were assigned to a physical therapist, were assigned to actually a gym, and there was a coach that would tell them what they needed to do, and they were followed and so on. And then you had chiros, and that, the group that really did well were actually people that were just out doing some exercise, and that they were gauging to a certain degree how much, and that they took upon themselves that activity and that desire to move and so on, and that these were the groups that did the best. I would definitely raise a concern that if you do have a connective tissue disorder, some of the chiros, some of their treatment is really cervical manipulation, occipital cervical manipulation, and for patients that have this condition, you're putting yourselves at risk not only of certain paralysis, and there's some case reports, but there's also vascular dissection with vertebral artery subsequent to violent rotation. Some of the vessels that go to your brain actually tear. And so I would tell you that the term chiro means a lot. And unfortunately, there's a lot of different individuals that provide different care, they say. So I think that from and this is just, it's not me as an orthopod saying I'm against chiros. I have a osteopath chiro in my clinic that does very specific patient pathology that I feel will be beneficial.
Yep.
But one has to be careful, especially with these underlying hyperlaxity and cervical pathologies. So.
I would totally
Words of
agree.
caution, yeah.
With Dr. Loeys' point. And just to say, for the cervical instability, especially the vertebral artery has a very tortuous course at C0, C1, and C2, and it's very prone to injuries. In fact, even when we do some fluoroscopy-guided injections, we try to be very careful in that area, and we call it a tiger territory usually. So any kind of manipulation which involves a cervical spine should preferably be avoided in patients with connective tissue disorders. The second thing, coming to the physical activity, there's a huge amount of literature and new literature which shows that aerobic activity is not just good for cardiovascular fitness, but also what aerobic light physical activity does is that it increases endorphin release. And it also that affects the local endocannabinoid and endoopioid receptors, so it has itself a nociceptive effect. Also, what it does is that it increases the level of serotonin and balances the serotonin dopamine pathway, so the patient feels better. So it's already an antidepressant and analgesic in itself as well.